Yeah, great. Thank you very much for having me. And the introduction. I was asked to present something on disruptive behaviors and parent management, and this is going to be my first time formally presenting on something. But I could say that this is definitely a common area of concern, whether their individuals are being referred to a child psychiatric clinic or families are coming for their first time. To kind of get things started, don't have any financial disclosures. My approach, I wanted to make sure that I was focusing on, given that was an echo presentation, I wanted to make sure that my understanding is I'm working with community providers here in the state of Hawaii and then maybe neighboring islands. And so I wanted to ensure that we were taking into account things maybe such as culture, as that can influence outcomes, and not rely extensively on just typically data arising from mainland sources, which may not necessarily translate well, but really focusing on what are the experiences we're having in the clinics here in Hawaii that are producing outcomes and things that, if I could share with the PCP, I would. And the other caveat was that I wanted to arrange this such that it would meet the needs of a PCP or let's say an NP who's typically following kids for 15, 20-minute follow-ups, as those are different constraints than the ones that we work in, as we typically can range anywhere from 30 minutes to an hour. We can see individuals maybe on anywhere from a weekly to bi-weekly or a monthly basis. And so and my goals were kind of twofold for the PCP provider. One, to identify which types of things can actually respond to quick intervention, so that may feel like it's within your domain of control, and then it's worth actually following up just for like 2 or 3 visits to see some results, whereas which are some of the things that may actually require greater effort. And so a sooner referral may actually be beneficial, and that will prevent the problem of concern from growing to even greater severity over time, and thereby possibly making it a little more treatment resistant. So I have some questions, and I believe Summer is going to run the polls. Is that correct?
Yep, I'm going to put it up right now.
Okay.
I'll leave it on for about another minute, about 20% participation right now. So we'll let it go a little while.
Okay.
Don't be shy if you don't know the answers too. You're not supposed to know at the beginning.
Okay, maybe another 10 seconds and we'll go ahead and end the poll. Thanks, everyone. Okay, great.
Right. Yeah, this is really informative for me as I design questions and kind of where I can change things up to make it a little better next time. Thank you for that. So shall I continue? Okay, great. So feel free to throw these into the chat box now. This question is tailored towards pediatricians, primary care providers, NPs, anyone working with kids on a regular basis, what type of disruptive behaviors challenge your clinic? So feel free to, you can share it in the chat, or you can just type it briefly. Maybe that's a current problem, or maybe it's a type of issue where, if the staff write this as a presenting concern on the chart before you go in, you're like you already feel your heart rate pacing, because you know that it's going to be a bit of a challenge dealing with this. And that's going to be helpful for me, partly in terms of tailoring this conversation, but also if there's opportunities for a future presentation, maybe to decide how can I deliver a more, effective or valuable presentation for you guys. So as you take a moment to do that, I want to give you an overview of what the presentation is going to include. So disruptive behaviors are pretty broad. It can be pretty much loosely defined as anything a parent doesn't want their child to do, broadly speaking. And so presentations can typically include, for younger kids, anxiety, mutism, panic attacks, depression, tantrums, food avoidance, or sibling rivalry. And mind you, sibling rivalry is not always necessarily a problematic issue, but it can be considered disruptive by the parent. And then for older kids, say teenagers and the like, we could be seeing presentations such as anxiety, depression, violence, more severe presentations such as property damage or runaways, substance use or eating disorders, or high-risk behaviors such as sexual activities, especially unprotected sex. So looking at the causes, we can roughly divide it into kind of two groups, both medical and behavioral. Looking at the medical causes, ones that we typically see if they do present themselves, oftentimes when I'm checking on the unit for a kid that's presenting depressed or what seems to be lazy or slow as they're being accused by the family members and they're really struggling, anemia is not uncommon in these young females. And maybe they're early on and they're only soon after have they started actually their menstrual cycles. This is a time where it's very confusing for them. As you probably know well, they're still trying to figure out how to manage their symptoms, and they're probably suffering from the effects of anemia, but that's gone on undetected. And not often, but it's not uncommon that when I check a hemoglobin and hematocrit that I actually see in a young female, this might be a contributing portion of the challenge. Another could be seizures. This area you're probably well familiar with, present as inattentive or actually sometimes disrespectful, depending on how the parent reads into it and their response to the child. And this is not necessarily always the case in that they may have a primary seizure disorder, but something to be aware of is that even if they were receiving treatments for their seizure, I've had cases where a psychiatric medication was started because almost all psychiatric meds, including classes of antidepressants, antipsychotics in particular, are more likely to decrease the seizure threshold and thereby increase the presentation of these events. And so oftentimes parents will be seeing a neurologist, for instance, for a child with a case of epilepsy, and then they're started on this psychiatric medication and they feel maybe the child is acting out more and there's some unusual behaviors that are started up. And the neurologist is checking the blood levels as they're notified of this presentation and everything seems normal from their end from a treatment perspective. But when in fact it actually may be a breakthrough of symptoms as a result of the psychiatric medication. Substance use, teenagers may seem lazy or they may seem aggressive depending on the substance of choice. This is actually the least commonly seen presentation in the outpatient scenario, but it does depend on the population you're working with. One of my clinics that I work in is at the Youth Correctional Facility at HYCF here in Oahu and Kailua. And there, for instance, you oftentimes, or a detention home, you're seeing kids detoxing from a variety of substances that they're exposed to. And so more often than not, during the initial presentation when they arrive, I tend to have more of a hands-off approach. I'm not very heavy-handed with medications at that time. My only goal is for them to sleep, and so as to kind of accelerate the recovery process. But other than that, I'm not trying to identify a primary mood disorder or inattention disorder for that first month or so. Sleep disorders. This is probably the most common cause that I see in the clinic in terms of a medical cause. And that can present with a variety of causes, whether the child appears depressed, and that's with kind of the chronic fatigue presentation. They become very anxious oftentimes, and it can be a contributing factor to a kid who's already predisposed to anxiety. They can present with cognitive symptoms, appearing that they're inattentive, or maybe they're lazy, and this also decreases their frustration tolerance, where so they can seem more agitated. And so, just think of yourself, the times where, you were on call, or, you've been sleep deprived for maybe a day or two, or the time when, if you're a parent, and you've had a child, and and the child wasn't a good sleeper, then, how loss of sleep was something that contributed to your overall presentation and state of mind, and also the interactions you had. Now, for a child, if this is usually a chronic sleep disorder, and so they have an undetected case of sleep apnea, for instance, just keep in mind that this has been going on for years in their life. And so it's not uncommon to actually see the symptoms compound over time. And what I am finding is that even with myself, the cases that I am checking, oftentimes I'm catching the severe cases, which is telling me that I'm missing a substantial fraction of the mild to moderate cases. And there's excellent literature demonstrating, at least in the adult, but likely the youth population, that individuals are less likely to respond to an antidepressant medication or another intervention if there's a comorbid sleep disorder and it goes untreated. And of course, it could be a primary mood disorder, anxiety disorder. More often, actually, in the youth population, it tends to be secondary. So meaning the individual presents with depressive symptoms or anxiety symptoms, but it may be secondary to some sort of stressor in their environment, typically family, friend, or school related. So I think something to keep in cause, and that's important to perform a workup, and checking the hemoglobin, hematocrit, or iron studies in menstruating females, a sleep study for kids, or to reevaluate the medications if they have a potential for decreasing the seizure threshold, is to make sure we take the time to actually do that, because it's extremely discouraging for, a child to be blamed for symptoms that they're suffering from, and then for them to go to a provider and be told that things are okay from a medical perspective without that evaluation, and then being referred to psychiatry. And unfortunately, sometimes that is the case. And, when we do check, I think there are lost opportunities where, a child may have actually received much more rapid intervention had they had the opportunity to have these studies carried out. And especially the sleep studies, because it tends to be a much longer drawn out process, in that you have to wait for them to get into the sleep clinic once they do seeking out interventions. And so this could usually be a 6-month turnaround time from the time that's detected to the time that an effective intervention or multiple interventions have been provided for the child for resolution of the symptoms. So oftentimes, what we're looking at is we have a variety of providers in the community. In Hawaii itself, there's Sleep Center of Hawaii, located in Aiea, Neolapua, which is not too far from Queens, and then the Kapiolani Medical Center, all of whom work with children. ENT may play a role, whether it may be, and we usually just have them evaluate the oral pharyngeal passages. And it may be beneficial for, a tonsillectomy, adenoidectomy, as a lot of individuals are familiar, but sometimes there's other interventions that they can also look at, going beyond just that, or chronic nasal steroid application. In terms of medical causes, if all the medical causes are ruled out, something that a provider could use, and it's not uncommon in child psychiatry, are scales to help you kind of nail down or give you greater confidence in the direction of which you want to refer. So for children, we use something called the CESDC, which is a long name, but if you just type that into Google, that's used for depression. The SCARED, which is used for anxiety, and there's a copy for the parent and a copy for the child. And what's interesting is oftentimes when you run the results, you can see the difference in how the parent perceives the anxiety versus how the child perceives the anxiety. And then there's the Vanderbilts, which you're probably very well familiar with. And not only does it cover ADHD, but a variety of disruptive behaviors. And so if I had to pick one, I would actually go with the Vanderbilt, because I feel that it's kind of the most broad, and it checks for the parents and also teachers. So it gives you really good perspective. And in the case of primary psychiatric illnesses, and that includes things like ADHD or a learning disorder, typically there is a family history that's positive. And even if the parent is not aware, Sometimes just kind of taking a moment to observe the parent, that'll usually present, especially in the cases of a learning disorder or ADHD, you may actually pick up on something there, or asking questions related to those symptoms for either of the parents. For behavioral causes now, often, so, with the medical workup out of the way, the three most common situations that you could look at are essentially a child who's demonstrating behavioral issues, and it's typically as a result of lack of structure in the child's life. There's the school avoidance, and it more often tends to be associated related to workload rather than peer issue challenges, at least with the population that we're seeing or I'm seeing, and then also parent-child conflict. So looking into management for that, there's at the first challenge in terms of an unstructured child, routines really are the building blocks for success. And that pretty much, I feel like, is the definition of, probably everything that's alive, if you think it of, whether it's a bumblebee or an amphibian or an adult, we all depend on these routines that we carry out. And that really automates a lot of the necessary processes in our life, whether that's sleeping, eating, activities, or carrying out our work or studying. And oftentimes with kids who have disruptive behaviors, you'll usually find that there's an erosion of their of those routines, and it typically occurs around transitional periods. And so the parent may have a state of mind where they're trying to apply maybe a routine or an approach when they're at a younger transitional stage versus an older transitional stage or older developmental stage they're at now. So that could be with starting school, or maybe advancing to the next stage of school, going from middle school to high school, where a child is now expecting more autonomy, or major life changes, as we saw with the pandemic, where, if you think of the school as the third parent, the parent that, was the one providing education and instruction for the children from 8 to 3, Monday through Friday, for 10 months of the year, that third parent was lost, and we saw the effects of that. Or the loss of a loved one. And especially if that loved one was an individual who was instrumental in establishing the routines. And so maybe it was mom, and she was always making sure kids had the breakfast, they had their morning routine, expectations at school, and then she was also setting up their bedtime routines. Well, when the responsibility is put on dad, if he was never really familiar, he was aware that there was a routine, but didn't really know what those routines consist of, you notice that the kids start kind of falling apart as that implementation is kind of lost. And so reestablishing them is really critical to ensure necessary processes are preserved. And so the big 5 necessary routines are the ones that we probably all use in our life. What is the morning routine for the child? What is the school day routine in terms of adolescence? And if they're getting overwhelmed with workloads, how are they utilizing their free time? Are they socializing more? And in fact, they could use the study period to get ahead on their work so they have more free time in the evening. Or for kids who are really socially anxious, do they prefer to study because it helps them get away from the other kids? And really, should they be out there socializing, for instance? Or even the kids suffering from the depressive symptoms, where the social element may be more of an important factor. The after school routine, what do they do to take time and unwind for themselves? That's going to be an important feature as they learn to relax and kick back. And then the evening routine, and, depending on their age, is the child focusing on reading, developing their necessary academic skills, or they're finishing their homework, or actually pursuing hobbies, and they're trying to prioritize that. And then, of course, the bedtime. And so a lot of kids usually have a bedtime, but they don't have a bedtime routine. And that's often an issue we see with kids who have challenges sleeping. And so what are they doing in the last hour before they go to bed? Do they have some sort of process of getting ready and going to bed, or are they only waiting to the point that they're so tired that they're passing out? And that usually ends up being the individuals who have poor sleep. So in terms of incorporating, one of the helpful tips is, oftentimes parents, if they're dealing with a child who's a little more rebellious, or, they're a little more independent in nature, they may find that it's difficult to develop these routines and then have the child kind of follow them. And, with those individuals, but also the kids that are actually more likely to give the decision-making role to the parent, it's going to be, for both groups and for different reasons, it's important to incorporate them into it. Because one of the responsibilities is not only to help that child develop the structure so that way they can learn to function automatically and all the necessary things, but you also want them to develop competency in these areas. And so if they are going to make a mistake in making, in let's say, changing the order of their routine, it's better for them to learn it while they're younger and while they're more responsive, and you're going to be more included in that decision-making process rather than having them figure it out when they first head off to college. And second group is with young children. It's usually pretty easy. What you do is you kind of focus on giving them a couple different easy options to pick between, and then you just have them decide on the order of things, and they feel like that they have a greater stake in the decision making. With adolescents, that usually ends up causing a lot of resistance as they want a greater sense of control, which is a good thing to respect. And so rather you want to focus on more so defining expectations with the kids as they become more principle oriented, and then have them create their preferred routines that accounts for those expectations. And usually when we speak to kids, and when I speak to kids, they're often quite reasonable and, and understanding that there are things their parents think are good ideas that they agree to, but it's just the approach and how the parents are coming at it that's creating a lot of the discord between them. And so one of the things to keep in mind, I remember speaking to this mom, and she was having a challenge really trying to have her kid take part in all these various chores or responsibilities or completing his schoolwork. But she really just kind of, and what they felt over time was they kind of kept just going at each other. And I had her kind of take a step back and recognize, what is it that how is it that we can make this a little more fun or a little more interesting? And it's important to recognize that, some kids actually like cleaning in the same way some adults do, or having an organized space, or having the opportunity to prepare before they go to sleep. And the ones who do typically have a different perspective on it than the ones who don't. So fostering that perspective and having conversation with the child, and also giving them the autonomy and loosely structuring things so that way they can understand which direction to go in, so that way it seems of something that's important to them, will actually make things much more likely to have a child who's internally motivated to carry out things, rather than feeling like there's a rule system just lined with tons of punishments and rewards if they were to move in any given direction. And that's really what you want. You want someone who's internally motivated to execute on these things. In terms of looking at the challenge of schoolwork being overwhelming, more often than not with these kids, it usually tends to be organizational skills haven't been developed with them. And so parents need to recognize that by the time a child hits high school, they need to have figured out the skills of scheduling, prioritization, and preparation. And so using their agenda or their planner or their phone, if the parent wants to provide that, and actually scheduling their life to recognize, when is it a good time for me to hang out? When is it a good time for me to get my work done? And then also in terms of prioritizing things, often anxious kids or those who tend to procrastinate will prioritize things from easiest to hardest. And that usually causes a lot of problems. And what they need to learn rather is how to prioritize from most important to least important. And so for them to understand, maybe there's a test or a project which is worth more, or there's an activity which is more important to them versus another one which is less important, but maybe there's other people who find it of more value to them. And they need to take time and reflect on these things. And when you notice that they develop these skills, usually you see the work performance starts improving. And also to get into the habit of preparation. This tends to be a common challenge with not only kids that are disorganized, but kids who are usually very high functioning. If they've been fortunate to be, just born and they were really smart and they've always been kind of top of the class without much effort, and they always were able to get their homework done. Usually when the workload starts increasing, they get to grade 11, grade 12, and then the challenges really start mounting as they're trying to balance a social life, personal hobbies, and then also their work. They really start kind of getting overwhelmed as they've always kind of developed, dependent on kind of their biological advantage to kind of get them ahead of things. And so getting into the habit of preparation for tests, or preparation even for social events, as they're learning how to speak with their friends and actually set boundaries of identifying when are their times they're going to focus on their work. This is often a skill that they need to use. And so if a therapist is going to be found for the kid, one thing to keep in mind is that, you know, the first therapist is not always the best therapist, as many of you are always aware, might be aware of. And often finding one is like trying to find someone to give you a haircut. And so their compatibility is usually a big part of determining whether or not the lessons being taught are going to be beneficial for the child. But also the other one is looking for outcomes. So if you do tell a parent you happen to refer them to a therapist in the community, you know, as you follow up with that parent, be sure to check in and check in and see, you know, are they meeting any sort of meaningful outcomes for the child? And if you notice, you know, 6 months, 9 months, 12 months go by and you're not really seeing results, you know, a discussion should be had as to whether or not this is going to be the appropriate provider, even if there's a high degree of compatibility. And also, you know, has there been an effort for the parent to also work with the therapist to define some goals for the child as well? And so oftentimes, if you leave it up to the child, they'll just pick the person that they find who's their favorite to talk to, which may work very well. But sometimes that's not the case. And usually they're actually relegating certain roles to the therapist, which actually should be relegated to the parent. And they're not going to the therapist to develop skills, but they're going there to necessarily more so find a friend, is what it seems like. Schoolwork is overwhelming to kids as doctors are overwhelming to parents. And so this is something to keep in mind, is that if you have, when you're working with a family or a child, it probably, in the same way you probably want to help kids who are facing obesity, you know, overcome the challenges they're facing to lose weight. Probably providing an extensive list of all the things they can eat and the number of minutes of exercise they use today probably doesn't produce robust results. And you know, our literature shows time and time again that the only way to really get us to get effective results is you got to have just one request or one discussion to be focused on at really each visit. And so if that's focusing on prioritization with the kid, or preparing more regularly, or planning routines, pick one. Don't put them all on the parent's plate, because ultimately what you're going to find is that it's just increasing the chance of failure. And that usually leads both the patient and the parents to becoming dissatisfied, and the provider becoming apathetic to the cause. And so, and really, when it comes to improvement and satisfaction, people don't really experience the state at which they're at. What they tend to experience is the kind of change in state. And so if each visit they're coming back and there's a noticeable improvement, despite it being small, you're actually going to have more momentum to build with. And the other thing that I want to point out was oftentimes we want to present the plan. So we want to tell the parent what does a morning routine look like? What does a bedtime routine look like? You know, what does it look like for the child to prioritize his schedule when he comes home from school? That is something I recommend you avoid, because it's more likely than not to fail, because it usually doesn't account for all the practicalities of the child or the parent's life. And it also fails to actually accomplish engagement or ownership from the people who are actually involved in the problem. So rather, the focus should be more so Socratic in terms, and that you should be explaining to them on a principle level, routines are necessary, and we need routines to guide the child. Now, let's take a moment and focus on, here's 5 routines. Let's develop 2 routines together right now. For the morning routine, you as a parent, tell me what the morning routine will be for the child. And at first, they're always going to say, I don't know. And then you say, okay, I believe in you. You just give them some words of encouragement, and then you just stay quiet. And then you'll start seeing them, the gears will start moving, and then they'll start listing things. They'll say, well, we can only do this because there's this person in the house, and we can only do that, but we can definitely move things around. And then you'll start hearing, when the gears turn, they start putting together an idea. Have them do a second routine. And then from there, once they have something in place and they understand how to do it with a couple of routines, say, okay, why don't we follow up in the future to see what the effect of having all 5 routines in place will be? And you're going to notice much greater rates of success with this type of approach. Parent-child conflict. So this happens to be a matter of interactions, which typically lacks an understanding of one of 3 things that it can be broadly grouped into. So typically the parent is usually, they don't have, actually that's a typo, but they lack an understanding of a correct age appropriate approach So rulemaking for structuring versus discussion for self-structuring. And the two of those, for instance, rulemaking would be more so useful for a young child, whereas a discussion would be more so useful for an adolescent. And then positive interactions versus an excessive behavioral approach. So oftentimes we learn from behavioralists and psychiatrists or mental health providers that one of the easiest ways to have a child change their behavior, or from all the popular books that exist out there, is that we want a reward punishment system, and that'll help a child lean more in one direction and move further away from another direction. But what's not understood is that is actually very good for very well defined interventions. So for instance, if we want a child to, when they come home, we want them to put their shoes in a specific spot, wash their hands, and wash their face. A reward punishment system will work well for that because it's well defined. But for instance, if we want the child overall to cooperate more, and we feel like we're constantly butting heads with them, and the parent is pulling their hair out, and they feel like at every turn, despite having defined the boundaries well, them being able to articulate them, having discussions and explaining it, and having a whole reward punishment system in place that they've used time and time again and has still failed. That is not really a well-defined approach, but really what you're describing is more so the child's demeanor that you're trying to change, rather than a very specific instance. And in that case, it's actually the interactions that the parent is having with the child, not so much this very tightly defined behavioral paradigm that will be effective. And then the third, which I italicized, is the concept of parental mutual respect. So high conflict divorces, separated parents, which are not speaking to each other regularly, or you have children which are moving between two parents and they're gaming both parents. So they go to the one that's providing them greater resources, more autonomy, and then they tend to jump back and forth whenever the going gets tough. And then over time, if that leads to an extreme, then people will identify them as a borderline individual. And then earlier in the course, they'll identify them as being oppositional. But usually the challenge is, if you actually look at the family system, the parental system is actually where the disruption is, and the child's behavior is just merely a response to a fractured system. And so what we see is, one of the most kind of quintessential cases that come up is the overworked, underpaid single mom with a disengaged father, and who presents with a misbehaving child. And so oftentimes in those scenarios, if there's a primary mood disorder, that could respond to a medication. But really what you're looking at in these cases is you're looking at someone who's just overwhelmed and unable to really effectively care for their child. And their support system is really lacking. And so when I talk to them, usually maybe they can't depend on their parents, who may even live on the island, or they can't depend on their siblings for some help. And so helping them expand that social structure around them really can have a huge impact on feeling supported and getting the help they need for being able to kind of gauge things with the child, and also re-engaging the father. And so this is something obviously you couldn't really do in a clinic in a 15-20 minute visit, which is why from a family therapy perspective, this tends to be a common intervention that's conducted. So I was asked to put together a few vignettes for the case, for the presentation. So these are all cases that have actually taken place. So they're real cases. I had this couple came in, Japanese-American family, and 6-year-old boy whose parents were struggling with him, trying to teach him to respect them. His tantrums were specific to not getting what he wanted from them. He did well academically. He was engaged in multiple sports. His teachers and coaches all provided positive reports of his behavior. But when speaking to his parents, they revealed mom had very clear routines and expectations. However, dad preferred to parent from more so of a principled basis with no defined expectations for routines. And then so it was clear that dad, he just wanted the child to understand the concept of respect. He wanted him to understand the concept of respect in all areas of his life, and what he would try to do is try to parent kind of shooting from the gut with that principle in mind. And then what that would lead to is things like dinner time routines, getting ready for bed. They would vary from a day-to-day basis whenever it was his turn to take over things. And so it was leading to some mixed messaging for his son. And so what they found was that dad had to understand that the principle of respect was an important expectation, but it wasn't being broken down into an age appropriate level that a 6-year-old could understand. And so what was done for him was that he was asked in clinic to translate the concept of respect into a morning routine, and then translate the concept of respect into an afternoon routine, and so on and so forth. And that had to be a routine that he agreed with his wife, because they wanted to provide a consistent approach. And so they've been going through this as we speak, and they're now starting to see the results of their son turning the curve. A second vignette. This is, I had a 16-year-old male, part Hawaiian, Filipino, and of European descent, with moderate intellectual disability, major depression, OCD, ADHD, and tics. He presented for mom's concerns about him recurrently flushing objects down the toilet. And he was enrolled, he's been enrolled in ABA therapy for 3 years. And his parents actually recently decided to stop treatment due to the limited outcomes that they were seeing. And they had grown frustrated with the interventions that had been tried. They had tried reward punishment systems, which had not demonstrated a response. Prozac did help with some depressive symptoms, the mood and anhedonia, but it didn't change his flushing of objects. And then the Concerta did help him pay better attention in class, but he was still oppositional with his mom. And mom herself was the mother of 4 children, including him. And she wanted him to focus on his academics, which usually was a cause of irritation between the two of them. And then so he would often then go to the bathroom, which would be kind of like his sanctuary. And then he would begin flushing the toilet. And if he was angry at his mom, he would flush an object down the toilet. And over the years, this has cost thousands of dollars, not only for their family, but for other families where he's flushed objects down their toilets. And but what's interesting was that the father, when exploring his relationship with his son, the father was the breadwinner. He was working daytime hours, but from a young age, the son has always listened to him, and they've always had a pleasant relationship, and he was able to motivate him. So the focus has been on mom refocusing her relationship with him as and when we started that conversation, she then began to express the regret of being a young parent when having him. And she was more focused on going out and having a fun time and being a 21-year-old. And she feels, in comparison to her 3 other children, which she felt like she was a present mother and has a close bond with them, she always has regretted that behavior of hers and having built that and not having built that bond with him. But what was important to point out was that her son, to this day, even though being 16 years old, was still yearning for that attention and for that relationship. And she had even pointed out that even when she needs him to wait for a prolonged period of time, if she would compliment him and praise him for being patient, he would respond very well to that. So the presentations that's at about 12:40, I want to make sure there's some time for discussion. And so I separated this area off into advanced management. I'm going to quickly just gloss over it because this is not something that I think a primary care provider would actually carry out in their office, but just to give you a glimpse of what we may focus on from a theoretical perspective, just so, by you being able to become aware of it, you can identify what the necessary intervention may be in the case in front of you and why that would need, for instance, someone with an expert skill set. So oftentimes things that would require intensive family work would be cases of suicidal ideation, eating disorders, conversion disorder, delinquency, selective mutism, or severe social anxiety. And then from a family systems perspective, these all represent scenarios where a child is typically caught up or triangulated is the term we use, in a conflict avoidant parental system. So mom and dad are failing to engage responsibly with each other. And this can actually present not only with lower functioning families where we think of, there's a lot of conflict and maybe there's violence or swearing and yelling, but actually in very high functioning families. So we have parents who are accountants or lawyers or physicians, and they tend to present very well when they come into the clinic as high functioning, they're working, they live a very good life, they've provided their kids with an excellent education, and it seems like they've ticked off all the boxes. But when you actually get both the parents in the room, the conflict avoidance is very present and very obvious. And you can see that oftentimes the kid is actually getting caught up in that system, which is when addressed, we typically see resolution in a lot of these symptoms. And so Just to give you a snapshot of a case that we might experience, for instance, this is a case that had actually happened. 15-year-old female, Caucasian, with anxiety and depression, presents for refusal to eat and 15-pound weight loss over the past 3 months. BMI has dropped from 12, or that was supposed to be 21 to 19, with restricted eating and increased exercise due to fear of being fat. Reduced caloric intake, weighing herself 2 times a day and checking her reflection throughout the day. The patient reports low energy, difficulty focusing in school and completing assignments, difficulty sleeping, and a desire not to want to wake up after she goes to sleep. And none of these symptoms were at her baseline, let's say a year or 2 ago. These are all new symptoms for her. And so that have kind of correlated with the decline in weight and the change in diet. Both a Prozac and a sertraline trial had failed. Melatonin had a modest benefit with helping her fall asleep and not stay asleep. Parents, when talking to them, both seemed normal. Both were educated working professionals who kind of presented this je ne sais quoi type attitude as to why their daughter acted that way. And then mom and dad are separated, with the child living with mom, who has become exhausted trying to force her daughter to eat. She's tried offering all her favorite foods, buy her whatever she wants, and has even permitted her to switch to online schooling so that way she could be more comfortable with her learning environment. Despite this, there's been no improvement in the child's weight or her behavior. Parents note her behavior has deteriorated months after their divorce, and the parents continue to remain in contact but regularly argue or avoid each other. And on interview, the child is often taking sides and is mad with one parent. And so this would be not an uncommon situation to face, actually, with a case of an eating disorder. And so what the goal would be is what we're typically looking at, trying to illustrate this, is that we have a parental system that's more so that on the right, where we have kind of this limited relationship between the 2 parents, and usually one parent is excessively joined by the child, and that's defined by the much thicker bar or much thicker line. And then the other parent has maybe a more limited relationship with the child, so they tend to be a little more disengaged. And that's in contrast to what would be an ideal system, where you see that the strongest relationship is not between the parent and the child, but between the 2 parents. And as a unified front, they're working with the child. And the significance of that is that in a unified system, you tend to have a consistent message. It's much more efficient, as each parent can depend on each other. And versus in a non-unified system, the child receives mixed messages. And it can seem like a diversity of messages, but while the parents may think plan A is much better than plan B, depending on which parent you ask, the child actually really doesn't care. What the child only cares about is for both parent A and parent B to come to some sort of mutual agreement as to what the plan even is. And so if the child actually with really smart kids sometimes, and if they tend to be a little more rebellious, then they'll start playing both sides of the parents for privileges. And that tends to, add fuel to the fire without their intention. And so it tends to be a very exhausting and desperate situation. And so the single parent kind of looks like a similar situation, but what we have is not only is it, do you have one parent disengaged from the other parent who's taking care of the child, but they're also disengaged from the child themselves. And so re-engaging that parent is going to be a major component in terms of reintegrating the family. And so in the family work, they don't see disruptive behaviorals as being an individual psychological phenomenon. And so they see it as really a feature of the system around the child having failed. And that's why oftentimes we don't see individual psychotherapy not yielding substantial results. And so the system needs to learn how to develop respectful communication, setting mutually decided clear expectations for their child with age-appropriate punishments in place. And this must be on a consistent basis. And oftentimes, actually, there have been NIH-funded trials where they've taken individuals with chronic anorexia nervosa. We're talking about 5 to 10 years on average having this condition. They've done extensive medication management, inpatient stays, extensive psychotherapy for years on end. And so these are very treatment refractory cases. And they've shown that a family approach with, I think it was roughly 80 to 100 individuals were in this NIH funded trial. They had a 90% response rate, actually remission rate. And 10 years later on follow-up, 88 or 86% of the original 100% of the cohort remained in durable remission 10 years later. And that's not something that we really see in the individual psychotherapy literature. So it's very powerful, and the effects of the social system maintaining durable results really is a critical component. If you don't change the system, you can't expect the results to persist over time. And so oftentimes what we have is we have in the clinic, the parents define what their expectations are. So I'm going to skip over going too detailed, but if a parent says they just want their kid to be happy, understand that that's a fleeting emotion. That's not a goal. You know, do you want them to be on time? Do you want them to have respectful interactions? Do you want them to make their work and also their hobbies a priority in their life? Those are expectations. And challenges should be expected throughout the process. And in terms of including adults, we have to recognize that you have to get all the decision makers in the role. So if there's grandparents that live in the home, they could be critical because they could be opposing the parents' efforts to move the child in a certain direction. And in some cultures, say for instance with Chinese families, if you don't get the grandmother in the room, she really is the hidden decision maker, and the parents will constantly face challenges, is what we've seen. Or I believe, if I'm correct, with Japanese families, but I also know this is the case for Indian families, if you don't convince the father, then the system really fails to turn the tide. And so oftentimes they'll continue to keep giving resistance. But once you get these decision makers involved in the actual situation at hand, you will find them becoming your biggest proponents at making sure that the family executes as expected for the sake of the child. Of course, there are pharmacologic strategies. These ones you guys are probably already aware of, and you receive presentations, whether it's things such as stimulants for ADHD or SSRIs for persistent irritability. The most important thing I can talk about here is that in the same way genetic conditions are inherited for mood disorders and learning disorders, they're also inherited in terms of medication response. So if the child or if the parent or a family member has responded to a given antidepressant or stimulant, consider trying that one first. And sleep aids can be helpful, but if you notice that the child requires refills regularly, then understand that there's something wrong there if a child cannot sleep well on a regular basis. And so if you notice that you're having to prescribe more than a month or 2 months of medication, one should really look further for causes. And so sleep studies can be very helpful at identifying what the challenge may be. And it's important to not get distracted by merely seeing what the report says in terms of its summary line. And what I've seen is sometimes providers will say, well, it's just mild case of sleep apnea. I don't have to really worry about that. But you have to understand that you don't use the report to guide your decision making. You use the report and your clinical presentation to guide the decision making. And so if you have a kid who's presenting with these symptoms, and there are mild symptoms that are identified on the test, that could very well be sufficient to actually having the kid present with the problem in front of you. And we've had a number of cases where treating mild cases have improved the presenting concern for the child. And so typically when they come to child psychiatrists, we may also look at off-label use of medications. And then one of the advantages family therapists have is not only have the experience working with families, but they will also work typically on a weekly basis for sessions of 30 to 60 minutes in length, which probably aren't realistic for a lot of PCPs. But if you're looking for a provider, starting with insurance companies, searching Google Maps is actually amazing for the state of Hawaii. I find a lot of great providers that way. And something to be aware of is Psychology Today is often cited, but it's not regularly updated. So don't be surprised if your parents go search there and they say they can't find anyone who's open or available. I just, I thought this movie actually greatly exemplified kind of what would be a great family approach, but here's actually a story of what could be the benefit of having a well-defined planning approach from a young age for a child, utilizing positive interactions for motivating that development for pro-social behaviors, and understanding the importance of congruence between the caregivers for the sake of the children. So I guess we'll return to the questions.
Okay. We'll give it another 30 seconds. Looks like a lot of people got it right.
Yeah, there we go. And then so, I just, before I say anything.
And while we're finishing up the poll, everyone, you can also throw any questions you might have into the chat. We've got about 6 minutes left.
It looks like that's about it. I'll end it there.
Okay, great. And then so, yeah, number one is correct. That's certainly a very easy question, something duly noted for next time. I think we had a greater diversity of answers for number two in the pre and the post. Actually, the two most common, this was kind of a bit of a test taking question in terms of the wording. So two most common behavioral causes of disruptive behavior in children. So it would actually be parent-child conflict and school avoidance. There's and then so in mood disorder, we're thinking of not so much of a, we're think of more primary psychiatric cause, but oftentimes, if it's like a depressive symptom, for instance, it's not a mood disorder we're dealing with, even if the child is presenting as if they're depressive or anxious, but it's usually the stress in their system related to the school they're facing, school work, or maybe it's peer relationships, or just trying to manage a transitional stage going from middle school to high school. And then also the parent-child conflicts. And then the third is that's correct, as the majority had voted, the child is less likely to act out with a unified parental system. And so I know for a couple of folks who did select a greater diversity of messages, just to speak to that, we actually want there to be consistent and focused communication, and for there to kind of be the fewer messages there are that kind of veer off topic, the easier it is for the child to kind of stay on track.
Great. Thank you so much. I think that's a really important message too, is to try to get that unified, structured approach to be like really incorporated into the parents' overall approach to anything that they do with their kids. And I think for me as a hospitalist, I so often witness that there's a lot of chaos and that kids are staying up till like, I'm talking like 3-5-year-olds staying up till like midnight, 2 o'clock in the morning. And the parents are really struggling with simple things like taking an iPad away from them, or having them eat at dinner time and sleep at bedtime, or wake up during the day. And so, I think that there's a lot more of that probably for those of us that are out there doing mental health work and doing primary care than we might necessarily realize if we don't ask about it. I think my guess is it's something that if you just scratch the surface a little, there are enormous numbers of kids who are really struggling with that question of structure and a unified approach. Do you think that's accurate?
Yeah, very much so. We can really chase that in pretty much all the cases that are presenting to us with younger folks, we find that if we address that, it's quite remarkable how robust the results are. A lot of times you're looking at within the course of several months, you could have remission of symptoms, full remission of symptoms, and durable remission of symptoms by just rearranging that structure and having the key stakeholders play a role. Often the hardest part, and the part that kind of takes the most skill, is bringing in maybe all of the individuals who play that kind of key role. But that's actually why the hospital environment is a huge advantage, because a crisis is at play. And so getting the parents to come in and getting that individual who's disengaged or that family member, they will come in because of graver situations at hand. And so the intensity of a crisis, utilizing that in a motivating way to get participants to change, as opposed to diffusing it and making them feel like it's okay and kind of moving past it, is actually can be very helpful at leading to that system change.
Thank you. Thank you so much for a really practical and applicable presentation. And I think lots of pearls that we can take back and try to use as our sort of, first round while we're waiting to get kids into services, and or that we can try before making referrals, which is one of the major goals of this series is, recognizing the severe shortage of mental health providers, psychiatrists, and others in the state, realizing that there's so much that we can't just put on these referrals because they're just such limited numbers. So it's really helpful. I don't see any questions in the chat, so maybe I'll just let us close 1 minute early and say thanks a lot to everyone for joining us. Thank you, Dr. Patel, for sharing your knowledge and experiences, and we look forward to seeing everybody in a couple of weeks.